Hi, everyone. Welcome back to Neurospicy Nursing. It's been a while since we've done a lecture. Today, I just kind of want to go over the respiratory system as well as the cardiovascular system. And with that, I'm going to be bringing up some previous anatomy stuff, and we're going to go through some medications as well as some disorders, if that makes sense. Oops, I'm so sorry. All right, so this is how blood pressure works. And I know saying that kind of sounds like whatever. But blood pressure is a really good indicator of how our cardiac function is, as well as our resistance. And by resistance, I mean like if we have arteriosclerosis, so that buildup of plaque on our vasculature, that's going to affect how our blood pressure is, right? Because that makes the space more narrow. And when we think of narrowing of arteries, I like to think of vasoconstriction, and vasoconstriction leads to an increase in BP versus having a more dilated blood vessel, it's lower. So there's two things to remember when we're talking about the heart and the filling of our ventricles and our aortas. Preload is the actual filling of the ventricles. So this is blood has either come from is now oxygenated and is in that top atria or is deoxygenated and in the right atria, and they're getting ready to be shifted either to the body or to the lungs for oxygenation. Afterload is the amount of pressure that your heart has to make in order to move blood to the rest of our body, right? Because if we didn't have any pressure, our blood wouldn't go anywhere. So that pressure keeps our blood circulating and it allows blood to go to our brain, to go to our toes, to go to our fingertips. Even those most distal places is because of that pressure in the ventricle. So there's a few different types of medications when we talk about blood pressure. Some of the most common ones are going to be ACE, ARBs, calcium channel blockers, and occasionally you may also see metoprolol, but that's more in my experience with it. We use it more for lowering of the heart rate and dealing with like heart conditions like AFib. Other things that we're going to tell our patients that have hypertension is they have to make sure that they are limiting the amount of salt that they have because more salt is also going to increase their BP. As well as exercise. Exercise can help lowering their BP. They also will make sure that they want like a low fat diet, increase their vegetable intake, and make sure that they also have a diet that's low in cholesterol. Because the cholesterol actually is what causes the arteriosclerosis, and it causes the plaque on the inside of our arteries. So we don't want plaque because we want our arteries and vasculature to be more opened up. We don't want it to close down. If they are diabetic, don't forget that diabetes directly impacts your kidneys, and your kidneys are really the main thing that affects your blood pressure. So we have to make sure that we're monitoring our glucose levels because we don't want to have hypertension it's still going to be primary hypertension technically, but it's secondary to the diabetes, if that makes sense. There is essential hypertension and there is secondary hypertension. Essential is the normal hypertension that you think of. Secondary is actually when someone does have hypertension, but it's caused by like if they have an adrenal tumor or an adrenal gland issue. That's secondary hypertension. Um, Other lifestyle things, if they are overweight, they should bring their BMI down. So they should lose about 1 to 2 pounds a week. That's normal. We don't really want to do anything more than that unless they are like their BMI is like extraordinarily high because it gets a little bit dangerous when we start to drop weight that quickly. It's not very healthy for your body. And then we're also going to limit alcohol because alcohol can also cause hypertension. Now, like I mentioned, there are multiple different types of drugs. Um, there's ACEs and ARBs, calcium channel blockers as well. All of these work on increasing that vasodilation so that your blood pressure lowers. Um, Other things to know about ACEs specifically. I just want to touch on this really, really quickly because it will most likely be on your test. Is that, well, one, look at the ending. If it ends in pril, it's going to be an ACE. Okay, so make sure that you keep that in mind. These medications are teratogenic, so you cannot take them while you are pregnant, okay? They block the conversion of angiotensin, and it is going to lower your blood pressure and lower the afterload. Things that you have to monitor for are a chronic cough. A chronic cough, if you see a chronic cough and they're on lisinopril or they're on enalapril, that's probably what we're reporting to the provider, that chronic cough. It's certainly an adverse effect. Other things for ACE inhibitors, hyperkalemia. They increase potassium in the body. So we have to monitor for signs and symptoms of that. And angioedema. This is going to be more common in individuals who are of Black descent, i.e. African American, Afro-Caribbean. But basically, it's just the swelling of the face, lips, and your throat. So that's an airway compromise. So we have to make sure that if they do have that, they notify the provider right away. ARBs block just angiotensin 2. For those who have had the chronic dry cough or they got the angioedema, this is a good medication for them to transition to. Though make sure that you know losartan also has the risk of the angioedema. So again, they are also teratogenic. They cause vasodilation, they reduce your blood pressure, and reduce the afterload. For these medications, you're going to monitor for dizziness and as well for hyperkalemia. I talked about beta blockers being used for blood pressure as well, metoprolol, atenolol. They also can be used for glaucoma and reducing intraocular pressure and that sort of stuff. But they're blocking the beta adrenergic receptors. And just, yes, they can be given for blood pressure, but it's more acute. They're just not given as, or at least I haven't seen them given as often for blood pressure anymore. Majority of the time I've seen ACEs and ARBs. Anyways, they block the beta adrenergic receptor. So when we're thinking about the sympathetic nervous system, they are what we call sympatholytics. There is a reversal for beta blockers. The reversal for beta blockers are actually going to be glucagon. So if you can remember beta blockers be gone with glucagon, then you're good to go. These medications are going to slow down our heart rate, reduce our BP, and decrease the myocardial oxygen demand. In these medications, we have to make sure that we're monitoring for heart rate. So if it's less than 60, we're not going to give it. We're going to avoid them in patients with severe asthma because since we're blocking the sympathetic nervous system, it's going to cause bronchoconstriction. And you will monitor for fatigue. For the calcium channel blockers, this is your amlodipine. It also has a reversal. Glucagon is a reversal for it. Insulin is a reversal, and you can also give calcium as well as a reversal. These medications are inhibiting the influx of calcium into the smooth muscles. So by doing that, it's going to cause vasodilation, reduce your BP, and reduce your heart rate. It's also going to reduce your calcium levels. So make sure that you watch your patient for hypocalcemia. You also need to make sure that you're watching for edema, bradycardia, and constipation in these patients. Here's some more about the specific medications I just told you about, this is a photo of the angioedema. And that non-productive cough is really what we want to make sure that they report that to the provider. All right, so for respiratory, we have a multitude of different types of medications. And with that come different delivery systems. So your nebulizer in the hospital setting, though, make sure that you know that nebulizers are going to be done by respiratory therapy. Nurses do not administer nebulizers. There's also meter dose inhalers. This is kind of like your normal inhaler. Spacers are just used in order to make sure that you get a really good seal so that an individual gets the most amount of that medication. Commonly seen in individuals who have asthma as a child. It's just so that there's a better seal and they actually get all of the medication. And then there's dry powder inhalers. You literally suck in a powder, and that's your medication. Okay, sympathetic and parasympathetic nervous systems. We've talked about it before. We talked about it last semester. Um, you can go look back at my video if you need to. But these medications are going to cover both the respiratory and cardiac symptoms. I'll give you an example. Albuterol. Albuterol works on the sympathetic nervous system. It dilates your bronchi. So in dilating your bronchi, you may also feel palpitations, tachycardia. All of that are symptoms of your albuterol. So you have to make sure that your patient knows that. Or else they're just gonna be like, I feel very shaky. I feel like my chest is like, it's not my chest. My heart is beating out my chest. That's the word I was looking for. So you have to make sure that you know that and you can recognize that and you tell them, hey, I'm gonna do an assessment on you, but I'm pretty sure that the side effects that you're feeling right now are from your medication. Okay, so this is just a photo of the difference between asthma and COPD. So, asthma most commonly is going to be diagnosed in childhood. Um, there's exercise-induced asthma as well, but not important for this test that you guys are going to be on or going to have. So, when someone has asthma, their airway is chronically constricted. So they need to take medications like their albuterol to open up and dilate that airway. And COPD is a combination of emphysema and chronic bronchitis. So they have a lot of mucus because of that chronic bronchitis. And then in emphysema, it's very poor gas exchange. So about 80 to 90% of COPD cases are caused by smoking. Now, occasionally when someone has pulmonary fibrosis, either from like COVID or something like that, technically they can transition into COPD, but a lot of times you'll just see it as pulmonary fibrosis in their chart. So there is a kind of ladder or step for how we give medications for asthma. Um, and then if they don't need it anymore or their symptoms are going away, we're gonna dial it back. So the most common thing that you're going to see an asthmatic patient have is that rescue inhaler. So this is that movie that you're watching, and there's the asthmatic kid with the glasses, and they were just running, and they go to pull their inhaler out of their pocket, but somehow while they're running, they drop it, and they freak out because they're like, I can't breathe. Do I go back and face this scary thing, or do I keep running? That is the rescue inhaler. It's also called a SABA, a short-acting beta agonist. Then If they progress and their asthma is starting to get worse, they are going to get low dose inhaled corticosteroids. So albuterol is a SABA. Inhaled corticosteroids, this is your like your Symbicort. It's like a red inhaler. But they are steroids. So you have to make sure that you're telling your patients, hey, after you take that medication, make sure you rinse your mouth out because you can end up with something called oral thrush. If their asthma has gotten worse or they're having a super acute flare-up, they are going to have a combo long-acting beta agonist with an inhaled corticosteroid. Now, if all of that is not working and their asthma is really, really, really severe, we can give them a really high dose inhaled corticosteroids. We're going to give them oral steroids. So if this is a diabetic patient, we have to make sure that we're monitoring their glucose levels because they're getting like double steroids. And the long-acting beta agonists, you'll see them on nebulizers. Also, if they have very, very severe uncontrolled asthma, there's new monoclonal antibody medications. One of them is called omalizumab. I don't know if I'm pronouncing that correctly, but this medication is going to bind to the immunoglobulin or your IgE levels to limit how much of the allergic response is being released in your body so that the airway isn't so constricted. Okay, so this is just a little difference in a SABA versus a LABA. So these bind to your beta 2 receptors to increase your bronchodilation. Again, tremors, chest pain, tachycardia. We have to make sure that we're telling our patients that these are side effects of it. If they take stimulants, if they drink caffeine, it's going to increase those side effects that they have. The other thing that you have to watch for is paradoxal bronchospasms. So this is when you go and you take your inhaler and you're worse off than you were before. That's what we mean by paradoxal. So instead of causing bronchodilation, they cause more bronchoconstriction. Okay, anticholinergics. Sorry, I can't see that. Or I can't say that. This is like Alavent, stuff like that, also for asthma, but it's instead of blocking the sympathetic nerve, or instead of activating the sympathetic nervous system, it's blocking the parasympathetic nervous system. So it works on a little bit of a different MOA, right? Because it's a different neurotransmitter that's being affected. So we're blocking acetylcholine here instead of activating norepinephrine. There's really common side effects for anticholinergic, and it's you can't pee, can't see, can't spit, can't shit. So if you can remember that, then you're golden. Also, anticholinergics can't be used for individuals that have glaucoma because of that whole can't see portion. All right, so theophylline. This medication it works very similarly to how our SABAs work, but different, right? These medications do relax your bronchial smooth muscles, so make sure that you know that and you remember that. So, since it's relaxing the smooth muscles, we should see an increase in that respiration getting better. However, this has a very narrow therapeutic index. It's only 5 micrograms that is the therapeutic index. And then once we get above 20, it starts becoming toxic to the individual. So, common signs of toxicity are going to be all of your GI signs, so the nausea, vomiting, diarrhea. They're also going to be very cranky, irritable, And then if it starts to progress even more, you'll see dysarrhythmias and even seizures. With this medication, they have to make sure that they are not taking caffeine because it's going to increase the amount of stimulation that they have. And this medication is also metabolized in the liver. So because it has such a low therapeutic index, we're going to make sure that we're monitoring our LFTs. Here's the inhaled corticosteroids I was talking about, and a photo of kind of how oral thrush is. This is not a rescue inhaler. Okay, so if someone is having an acute asthma attack, they're not going to take inhaled corticosteroids to immediately cause dilation in their bronchioles. They will take their rescue. The inhaled corticosteroids are for long-term management. Also, with that, because they are for long-term management, it takes a while for them to start working in your system. They will not be working overnight. And then the most important thing, like I mentioned before, they're taking steroids. They have to make sure that they are cleaning out their mouth because they'll get oral thrush. And the medicine for that, as an asthmatic who's had oral thrush once, is not very tasty. Okay, these are mast cell stabilizers, like cromolyn. So cromolyn is this. Honestly, to me, it's amazing because I have something called mast cell activation syndrome. So it has saved my life. Cromolyn is a medication that stabilizes your histamines in your GI tract. So it's a little liquid, and you put it into 8 ounces of water, and you drink it up to 4 times a day. 30 minutes before you eat breakfast, 30 minutes before you eat lunch, 30 minutes before you eat dinner, and then right before bed. And it just stabilizes it so that you're not having as many allergies. Well, you still have allergies, but you won't be having as severe of an allergic reaction to something that you eat, even if you eat it like by mistake, it stabilizes it. Then there's leukotriene modifiers. So this is montelukast or Singulair, if you've heard that name of the medication. They bind to leukotrienes, which are they're kind of like enzymes in your body that help, not help actually, they kind of inhibit, but they cause inflammation, and they can cause swelling. So we're going to inhibit those. Please make sure that you guys know that leukotriene modifiers like Singulair and slash montelukast have a black box warning. I don't think I put it on here. I did not. They have a black box warning. So what I mean by a black box warning is it's kind of like it's something that's very serious. It's a side effect that's very serious of this medication. That's not necessarily a quote unquote adverse effect. The black box warning for montelukast is the increased risk of depression, mood swings, as well as suicidal ideation. Please make sure that you guys know that for your tests. You will most likely see it. There's an increase in SI if you're on a leukotriene modifier. So when we start having, well, not we, but patient starts having thoughts of suicide, or that where they randomly start giving away all their things and all of a sudden are way more happier than you've ever seen them. Those are all red flags. And they're all signs of a progression and a plan to complete SI. Or well, to complete S. I can't say it on YouTube, but you guys know what I mean. Okay. And then it's also metabolized in your liver, so we're going to monitor our liver enzymes. Okay, these are the monoclonal antibody medications I was talking about before. Again, they bind to IgE levels and they're used for severe asthma. Whenever we have a monoclonal antibody, because these are given through the IV, we have to make sure that we're monitoring our patients for anaphylaxis. So normally they'll stay an hour or two after administration of the medication just to make sure that they don't have a reaction. Okay. Other medications that you might see are exportants. I can never say that, but it's guanfacine, which is basically Mucinex, antitussives, which is an anti-cough medicine, and then mucolytics, in this case, acetylcysteine is written. Don't forget that acetylcysteine is the reversal for acetaminophen, and that reduces like the actual thickness of the mucus as well. All right, so here's some of the red flags I was talking about earlier. Again, angioedema, dry cough for ACE inhibitors, tachycardia, and paradoxical bronchospasms for your beta agonists, glaucoma and urinary retention for your anticholinergics, seizures for methotrexate, can't say it, sorry, corticosteroids, oral thrush, and high glucose levels. Leukotriene modifiers increase risk for SI, depression, and liver enzymes, and your biologics are anaphylaxis. And that is all I have for you guys on that. Um, Again, if you have any questions, leave them in the comment section. But yeah, that's all I got for you guys. Thanks. Bye.